So good afternoon, everyone who's here. The topic for today is tuberculosis of the hip joint. So as you all know, this is an important topic for exams. During the last final MBBS exam, we had tuberculosis of spine. Okay, so the last time a question was asked on tuberculosis of the hip joint was in 2018. Okay, so tuberculosis of the spine, tuberculosis of the hip, tuberculosis of the knee joint, these are all important topics. So to start with, you might be aware that 1/4 of the world's population is infected by tuberculosis, and of these, 58% of them are in Asia. India has about 2 to 2.4 million of these cases with tuberculosis, first followed by China. Okay, so what we're going to talk today about is tuberculosis of the hip joint, which is part of the musculoskeletal system. And even though it accounts only about 1 to 3% of the total cases of tuberculosis, that's including pulmonary TB, extrapulmonary TB, okay, this number is still large because if you think of the number of cases in India, it is so much. Tuberculosis of the hip joint constitutes about 15 to 20% of all TB of the musculoskeletal system. So this may be very minuscule, but we do have a number of patients with TB of the hip joint. Okay, so how do these patients come and present themselves? They come to the OPD with a painful complaint of pain and restriction in motion of the hip joint. Okay, and usually it becomes very difficult to diagnose such cases. Most of the time, the presentation might be late, so it becomes difficult to diagnose. For example, in children, it can be because of a condition called Perthes disease. It can be because of juvenile rheumatoid arthritis, also known as JIA, or juvenile idiopathic arthritis. It can be due to transient synovitis. It can be some kind of bleeding disorder like hemophilia, or it can be due to septic arthritis. And it is important to differentiate the different causes of pain in the hip joint. In adults, it can be because of avascular necrosis or osteonecrosis, or simply due to age-related degeneration, inflammatory condition like rheumatoid arthritis and ankylosing spondylitis. Okay, so conventionally, it is said that it is easy to diagnose TB hip just based on your clinical findings and radiological findings. However, it is very important to diagnose it early if you want to get a good outcome. Okay, so with the passage of time, we are having many more modalities which we can use to diagnose, to confirm our diagnosis. So as you all know, osteoarthritic TB is basically secondary to a primary pathology, and this nidus is usually found in the lungs, it can be in the lymph nodes or in the viscera of the body. So it spreads to the hematogenous route, and the bacteria reaches either the synovium or the bone. When it lodges itself in the synovium membrane becomes swollen and congested. Okay, and with time, this synovium gets eroded over the bone, resulting in it affects the subchondral bone. What lies beneath the synovium is the bone, and below the bone is the subchondral membrane. And eventually, the entire synovium or the cartilage is worn out, and eventually a kissing lesion is formed where the bones start rubbing on each other. So it can lodge itself in various places, both in epiphysis and the metaphysis. There's a diagram up ahead. It can be lodged in the head or the neck of the femur. It can be the greater trochanter. It can be based in the acetylbulum. So based on this, it can be either inside the joint or outside the joint or nearby the joint, like what we see here. We describe it as extra-articular or juxta-articular. So when the disease starts as intra-articular, the progress is very fast and it involves the whole joint. So I mentioned this where you can find the different locations where the bacteria can lodge itself. It can lodge itself inside the acetylbulum, inside the femoral head, in the neck, to the greater trochanter. So this bacteria spreads faster if it's lodged inside the joint or intra-articular. When it is extra-articular, it can progress further, forming a cold abscess. And the location for this cold abscess is usually in the femoral triangle. It can be in the medial lateral posterior aspect of the thigh, or sometimes in the istiorectal fossa. So remember that if it is extra-articular, there is a high possibility of formation of a cold abscess. And this cold abscess can trickle. Basically, it depends on the gravity. It can be lodged in the femoral triangle or in the thigh. It can be also found in the istiorectal fossa. So the clinical presentation, this ideally affects the first few decades of life. But again, no age is immune. Okay? The main presentation is usually the pain in the hip. The patient comes walking with a limp. There is restriction in movement. So depending on the stage of involvement, there can be deformities found in the lower limb, there can be shortening, there can be swelling, there can also be a pathological dislocation and discharging sinuses. Okay? So it all depends on the stages. We'll come to the stages later on, I'll explain to you. So this is the first stage. The first stage is known as the stage of synovitis. It is important for you to remember these various stages. Okay? So here at the most, if you were to perform an X-ray, you'll hardly find anything. But on ultrasound, you may be able to diagnose an effusion inside the hip joint. You notice that the limb is kept in this position. It is kept in a flexed, abducted and externally rotated. Okay, so we remember it as FABER, flexion, abduction and external rotation. In the stage of synovitis, so the limb is kept in abduction and external rotation. And when you were to measure the limb length, you'll find that there is apparent lengthening. There's also restriction in terminal range of motion. So as the stage of synovitis progresses into the early stage of arthritis or the active stage, here you start seeing destruction of the joint. Following the destruction of the joint, the limb goes into this position. It is the case of flexion, adduction and internal rotation. So remember it is FADIR, flexion, adduction, internal rotation. And now instead of apparent lengthening, you have apparent shortening of the limb. The active stage now comes. Okay, there's muscle spasm. The movements can be very painful and the child or the patient walks in an antalgic gait. Okay, he doesn't put weight on the affected limb. So up till here, even if there's erosion of the joint space is still maintained. As it progresses into the advanced stage, there's marked destruction. Okay, the joint spaces become diminished and the hip movements are painful and grossly restricted. The limb further becomes shortened. So remember, in the first stage of synovitis, there's apparent lengthening. Gradually, there's apparent shortening, and eventually, with the final stage, there's shortening of the limb. Why? Because of the gross destruction of the joint. Okay, so you see here, stage of synovitis, stage of early arthritis, or stage of arthritis, and advanced arthritis. So the different clinical findings. In the first stage, you find apparent lengthening, followed by apparent shortening, then there's frank shortening and gross shortening. Okay, so even on radiological findings, you'll find at the most in stage 1. Why is it so difficult to diagnose this condition in stage 1? Is because it's not so clear. Unlike as it progresses to stage 2, you start seeing osteopenia, okay, and there's rarefaction in the bones, and as you progress, there's destruction, and when you reach stage 4, there's complete destruction. Okay, so you remember the 4 stages: stages of synovitis, early arthritis, active stage, and the advanced arthritis. So you remember these stages 1, 2, 3, 4, and this will basically help you to go about how to treat. Okay, so this X-ray shows a stage of arthritis. All right, so the right hip you can make out now. All right, the joint becomes hazy. The joint space, if you compare, becomes diminished. Okay, on the left side. So how will you go about investigating such a case? So when such and such a patient comes with this complaint in an endemic area, we first think of it as, we always jump to a conclusion that most likely our job is to rule out tuberculosis. Okay, so as I mentioned earlier, in endemic areas they say that you can easily diagnose it just by clinical examination supported by simple radiographs. Okay, along with that, the clinical features that you find: the patient comes with pain in the hip joint, he walks with a limp, there can be an antalgic gait, there's also a deformity. The deformity is flexion, abduction, okay, adduction and internal rotation, FADIR, F-A-D-I-R, that's the eventual deformity on the hip joint. And on the radiological features that you'll find here is, again, it depends on the stage which you see. There can be osteopenia, there can be soft tissue swelling, the joint space is simply reduced and the margins become fuzzy. Okay, so this should basically ring alarm bells. So in the stage of synovitis, it may be difficult to delineate on an X-ray. So the best way to confirm this diagnosis is to demonstrate the presence of tubercle bacilli on histology. Okay, but now with the easy availability of MRI, you can go directly to perform an MRI. Okay, while in an advanced stage of arthritis, it's more easier to diagnose it. Why? Because the radiological features are typical. There you'll find joint destruction, there's marked osteopenia, there's going to be rarefaction, there's going to be a decreased joint space. So unlike the early stage of synovitis, it's much more easier to diagnose it when it is advanced. It is also important to remember the various differential diagnoses. I already mentioned this earlier. You have transient synovitis of the hip joint in pediatrics. You can have Perthes disease. You can simply have osteomyelitis. You can have just a blunt trauma to the hip joint. There can be septic arthritis. There can be a tumor like osteoid-osteoma. The presence of polyvolunodular synovitis can also be there. Advanced rheumatoid arthritis, osteoarthritis. There can be osteonecrosis also, and there's also a giant cell variant. So these are the various differential diagnoses. So how to confirm usually is by MRI, and like what I mentioned earlier is to demonstrate the presence of tubercle bacilli within the hip joint, or even if you were to determine by taking a biopsy from the adjacent nearby lymph nodes around the hip joint, around the inguinal lymph nodes. So I mentioned this among the first slide that the most important investigation here that will help you to manage this case is early diagnosis. It is very important to diagnose it early. Okay? So I mentioned that this is basically a secondary cause. It can be you should also think that there's a primary lesion elsewhere. So it's important to look out. Say you have to perform an X-ray of the chest. Okay, but sometimes you might not be able to find out the primary pathology. Okay, other investigations that can help you is usually finding the complete blood count. You will find a raised ESR, the C-reactive protein, okay, and a Montus test definitely is supportive for your diagnosis. So we take into account all this in addition to your examination, the hematological investigations that you're going to send for, the radiological investigations you're going to send for. All these are kept together, and then depending on these you will come to your diagnosis. So the investigations again here, when you see them on a plain X-ray in early synovitis, does not show any finding at all. At the most you can find just soft tissue swelling. However, with further progression, there can be periarticular osteoporosis. The X-ray becomes hazy, the joint margins start becoming irregular and there's reduced in the space. Okay, so there's a classification by this person by the name of Shanmugasundaram who has classified the X-rays found in advanced arthritis. Okay, you have them as a traveling acetabulum, a wandering, a dislocated hip, the Perthes type, protrusio, atrophic type. Okay, so this classification is based on plain X-ray. So you remember this classification called Shanmugasundaram's classification of advanced arthritis. Okay, so here you have an example of the wandering acetabulum. You can see the X-ray of the left hip joint here, which shows a wandering acetabulum. Look at the size of the acetabulum and look at the size of the head of the femur. From there itself you can make out. Again, here you have a Perthes type of advanced arthritis here on the left hip. Okay, so the investigations here I mentioned earlier. Now that we have MRI to help you, it definitely helps you to diagnose this condition much earlier. Okay, however, we still depend on X-rays and you should not skip directly to an MRI. Okay, so in our country like India, since we have so many cases of tuberculosis, we still think about it. So most of the time when we have such a case, we can always think of it as tuberculosis. That's the first thing that comes to mind. However, in countries where it is rare, in additional to the clinical radiological findings, they have to perform ultrasound, MRI of the hip joint, and even a biopsy can be necessary. Okay, the tissue that is taken from the diseased hip can be sent for histology, for ARB, staining, and for culture and sensitivity. So the management now, I mentioned that early diagnosis is so important. It is important that way you'll be able to salvage the joint and prevent further damage. So the standard chemotherapy, everyone knows the 4 anti-tubercular drugs to start with, okay, HRZE, that's how we start with, okay. At the same time, we apply traction. Traction can be in the form of skin traction or skeletal traction. The role of traction basically is to immobilize. At the same time, it prevents pain and it also helps to maintain the joint space. If you want to prevent deformity of the opposite limb, you have to apply traction on the opposite limb also. Okay, so I mentioned already, traction relieves muscle spasm. It corrects deformity because with time the deformity, as you mentioned, as you've seen earlier, is FADIR, which is flexion, adduction, internal rotation. So with traction we hope to prevent further deformity. It also maintains joint space. It minimizes the migration of the acetabulum. Okay, at the same time you are allowed to observe the hip region. Another advantage is it keeps the joint surfaces apart. Okay, and this basically helps later on when you plan to mobilize such a patient. Okay, so with late presentation, these deformities become permanent. It becomes difficult to treat such patients. Okay, so TB eventually heals with chemotherapy when you give the 4 drugs. Okay, it heals with fibrosis. So you must remember that unlike septic arthritis or pyogenic arthritis, which is mainly caused by another bacteria like Staphylococcus aureus, which have proteolytic enzymes. Okay, so unlike in tuberculosis, again the articular cartilage survives for a long time because they don't have proteolytic enzymes, unlike pyogenic bacteria. Again, after starting traction along with anti-tubercular drugs, at about 4 to 6 months, partial weight bearing is permitted to the patient, and hopefully by 1.5 years, when the patient is done with his treatment of ATT, he is allowed to bear weight gradually. It is also important to remember that you have to improve the nutritional status of the patient. Just simply giving him only anti-tubercular drugs and traction with analgesia will not help. It is important to improve the overall nutrition of the patient also. Okay, so you've come to management already. You know how to go about management. Okay, so this is back to the stages what you've seen here. I'll not detail it again, but you've seen the clinical findings where apparent lengthening is there in the first stage, followed by apparent shortening, then shortening and gross shortening. Okay, so I'll not go into this so much. Okay, so a little bit about advanced arthritis now. In advanced arthritis, there is gross destruction. So what do you want here? So you see now, okay, there's diminished joint space already. So there's going to be shortened limb, grossly shortened limb. Okay, so at the end, after completing your treatment with tuberculosis with ATT drugs, the disease is healed, but the limb is shortened, and there's gross restriction of the movement. Okay. So in the last stage, in addition to your conservative treatment of ATT, you might have to perform these surgeries, which is called an excision, an arthrodesis, or maybe a hip replacement. So we'll talk a little bit about these small operations that we perform here. An excision arthroplasty is basically you're going to excise just the head and neck of the femur. Okay, so it's usually called girdle stones excision arthroplasty. So eventually, this provides a painless mobile hip joint. The patient is still able to squat. So this is how it looks like. You look to the right, after excising the diseased head and the neck, this is how it looks like. So this is a girdle stones excision arthroplasty. Okay. So as I mentioned just now, 90% of these patients are able to squat and kneel and even to sit in cross-legged, because our culture is such that where we still prefer to kneel and squat and sit cross-legged, we cannot afford a arthrodesed knee. Unlike here, if you arthrodese it, there's loss of movement, so it's understood. The joint is fused. When you arthrodese such a diseased hip, there's definitely reduction in the pain. You can even correct the deformity, but there's loss of movement. This is still very controversial because we are not sure about the reactivation of the Mycobacterium tuberculosis. So there are even suggestions of performing a total hip arthroplasty or a hip replacement. Okay, however, with time, with many other studies, people are gradually going into performing a total hip replacement. Okay, so you can see the X-ray, the diseased hips on the left side, and we have performed a hip replacement there. So the prognosis, again, as I mentioned, it is very important to diagnose this early. The earlier you diagnose it, the better the outcome. So it depends on the stage. If you are just diagnosing in the stage 1, stage 2, you often get a good result. As I mentioned, because it is not pyogenic in nature, it has no proteolytic enzymes, it hardly affects the synovium or the cartilage. However, when it is presented late, there is always some deformity. With the help of modern diagnostic tools, it is much easier for us to diagnose TB early. Okay. So to conclude, this is a common condition found in developing countries. The earliest presentation I usually find there's pain around the hip joint, the patient walks with a limp. When the patient comes delayed, you'll find deformities, there's shortening of the limb. Now remember, it is atypical. It is not like the pulmonary tuberculosis where you're going to have constitutional symptoms like fever, weight loss, loss of appetite. You may or may not have such things, so don't look for all these things. Even though during history you can definitely ask for that. Diagnosis is mainly clinical radiological. However, we must make good use of what we have, like ultrasounds and MRI, and histological proof is one of the best for diagnosing and confirming this disease. So management again depends on the stage. In the early stages, you may manage it just with ATT, but as you progress later on, this ATT has to be combined with the various surgeries I mentioned just now, arthroplasty, Arthrodesis, or an excision. Okay, so the last line here says an average about 2 to 5% of patients report with reactivation after 20 years. So we have to be aware of this. That's why we are still hesitant of going ahead with performing a total hip replacement. Okay, so among all the slides, I would say that this is one of the most important slides. Based on this slides, you can easily write a short note. So here, of all musculoskeletal TB hip accounts for around 15 to 20%. Early diagnosis and treatment usually yields a better outcome. So in an endemic area like India, for instance, just your clinical features and radiological features is enough to diagnose. But even though a biopsy will definitely help, you can see the various stages, the early stage of synovitis, early arthritis, and advanced arthritis. We call them stage 1, 2, 3, 4. With this, you can make out the deformities. So in the first stage, we have apparent lengthening, gradually apparent shortening, and gross shortening. So the clinical features, again, patient comes with a limp, with a pain in the hip joint. If it's an advanced stage, patient comes with deformity. Remember the differential diagnosis. In children, you can have Perthes disease, you can have juvenile rheumatoid arthritis. In adults, it can be due to avascular necrosis, it can be due to rheumatoid arthritis. So the treatment, again, it depends on the stage. In addition to ATT, there's analgesia, there's the application of skin retraction or skeletal retraction, and surgery in the last stages where you are trying to salvage the hip joint. Surgery is usually, again, arthroplasty, excision arthroplasty. It can be arthrodesis and hemiarthroplasty. So the prognosis, again, it depends on the stage of the disease. If you diagnose it early, the treatment outcome usually is better. So a small percentage of these patients down the line within 20 years usually reactivate. So these patients usually, even after you've completed treatment, they are supposed to come for a regular follow-up. At least within the first 5 years, they are supposed to come for your regular follow-up. Okay? So please remember the last slide. With the last slide, you were able to write everything about what you've learned about tuberculosis of the hip joint. So this is like, before I started this class, I mentioned that this is an important topic. Apart from TB of the spine, TB of the hip, TB of the hip, TB of the knee, and sometimes you have TB shoulder. But these are very common, okay? TB spine, TB hip, and TB knee are important topics for exams. So basically the treatment becomes all the same only, so once you know that. Okay, so with that, I'd like to end my class.